Order, order. Welcome to this special one-off session of the Health and Social Care Select Committee to look at the implications of the recent announcements regarding the abolition of NHS England, the cut to the head count of NHS centralised staff, if we want to put it that way, of 50%, but also the 50% cut to ICB running costs. So we have three panels today who have come to us at very short notice, and we thank everyone who's appearing in front of us today, because I'm sure, like you, we all just want to make a bit of sense about what this might mean, but also what implications and what dangers we need to be looking for as further details are announced. So for the first panel, may I ask you to introduce yourselves and tell us what you do, starting with Sharon Brennan, please.
Hi, I'm Sharon Brennan. I'm the Director of Policy and External Affairs at National Voices. National Voices is an umbrella charity with over 200 plus health and social care members, and we focused on lived experience, patient voice and health inequalities.
Thank you. So Henrietta Hughes.
Yeah, hi. My name's Professor Henrietta Hughes. I'm the Patient Safety Commissioner for England. I'm a practicing GP and a visiting professor at the Institute of Medicine, University of Greater Manchester.
Thank you very much. I'll start with Jane Craft.
Thank you, Chair. Good morning. So I'm very interested to kind of bear down on what the impact on patients of the NHS reorganisation will be. So what kind of differences would we expect patients to see due to the reorganisation, both in the sort of short, medium and long term?
So, well, the first thing I wanted to say is that thank you so much for inviting me to come here today, and I'm really delighted to be in front of this committee again. When I appeared at my pre-appointment hearing, I was asked what I was going to do, and what I've been doing is listening hard to the views and voices of patients, their representatives, but also frontline staff and leaders of multiple different organisations. And also to the MPs, the APPGs and members of the House of Lords. And I think what we really need to see is that these changes have a positive impact on patients. They need to have the listening to the patient voice as absolutely central to these changes, so that we focus on patient safety, on outcomes and patient experience. And I think by doing that, we'll be able to get the clinical engagement and the buy-in that will then help to really deliver the 10-year plan.
Fantastic. And what do you think needs to be in place in order for patients to have that greater voice in the running of whatever organisation replaces NHSE?
So I know that the Secretary of State is absolutely passionate about the patient voice as central to the design and delivery of healthcare services, and we've really seen that in the development of the 10-year plan, that really intentional, deliberative listening to people and communities and to staff. And I think what's really important is that that then continues in the delivery of the 10-year plan. So, for example, roles such as mine, which champion the patient voice as an independent commissioner. And I think that by having that networked working across a range of different organisations where we really have that focus, I think the very fact that the committee this morning, starting with the representatives of patients, then of the workforce, then of organisations, really sets the tone of the culture that we need to see in terms of the way that the health system works.
So a sort of patient-first focus going forward. And how do you think that the changes to the system specifically will enhance that patient voice, or could enhance that patient voice beyond what we see at the moment?
So by having simplicity, we know that patients struggle sometimes to understand which part of the system to go to. We know that it's quite a complex kind of labyrinth, but also that kind of navigation through the system as well. There are examples of great practice in that, but also I get a lot of correspondence from patients and their representatives who find that they don't really know where to turn in the system, and we help to navigate and signpost them if it's an area which isn't under my direct remit. What I'd really like to see is a much more cohesive and collaborative approach to listening to the patients, not only when they're in front of a clinician, but also in helping design and deliver health services in this country.
So, in terms of patient safety, are there risks, as far as you see it, to patient safety when the reorganisation takes place? There are some organisations that have flagged that reorganisation in the past has led to increased risk to patient safety while it's underway.
Absolutely, when there are changes happening, then, and I was, in the PCT when we had the last major reorganisations to the cluster and then to the National Commissioning Board, which became NHS England. And I think there's always a risk of a loss of organisational memory and people being quite distracted by what's happening. What I've done is I've spoken to current and incoming senior leaders in NHS England about what plans they have in place to make sure that there is an effective handover. And, I think that they're already starting to have those conversations. In my organisation, although very tiny, has multiple active pieces of work open with NHS England at the moment, ranging from valproate and mesh all the way through to deprescribing of antidepressants, thinking about consent and transparency, a whole range of different areas. And what I'll be doing is identifying who the policy teams will be that will be picking up on that work so that we can make sure that none of those kind of balls around patient safety get dropped in this transition process.
Thank you. And Sharon, what are patients not experiencing at the moment in terms of how much their voice is heard in the current system that you think they could be experiencing under a new system? And where are the current blockages that in a redesigned NHS should be taken care of?
So we know that patients are still struggling to trust the NHS, and we know they're still struggling with really basic things like admin. So National Voices, along with King's Fund and Healthwatch, recently published something on this. A quarter of people felt that the administration in the NHS was poor. 1/5 had seen letters appear for appointments after the appointment had taken place. So we're slightly worried that in the process of the organisation that could get worse. Around trust, we know that we've seen a lot of VCSEs working with patients to try and improve certain aspects of the care that are vital to them. So one example is Kidney Care UK has been working on improving access to individualised payments to pay for trips to dialysis, which has taken, they go 3 or 4 times a week. And we now know that that's an ICB-led initiative, which we now know might be under threat. So that's one initiative where patients are being involved in co-production, being promised something, and it looks like it may or may not go ahead. So initially there's something around trust and admin. In terms of where patients are less listened to, there is concerns and opportunities. NHS England, for all of its, you can argue whether it's worked well or not, but it does have a really strong focus on patient experience. It's got some very strong teams. It's got a clear purpose, and it's got PPI leads from ICBs feeding into that. And we'd want to make sure that that knowledge and that expertise is retained, and that we don't lose that organisational memory. But in terms of where patients are really struggling to be heard, it's really felt that there's little clarity of where responsibility for patient experience sits within an ICB. We feel there is a tendency for systems to not prioritise this work. And we're already hearing from our member organisations that people are facing cuts to co-production work from ICBs because of the 30% reduction seen previous to the narrow. So I think there's something about how do you ensure that patient experience is genuinely heard in the local community. And we're struggling to do it now, and I think with the cuts in the ICBs coming, it may become harder, especially if there's conversations around merging, and so the ICB footprint remains smaller, grows larger, while the communities remain the size that they are. So I think there's something around that.
Thank you. So would you say it's almost a lack of accountability, that patients experience at the moment that they find quite frustrating? And so is it around population size? You're concerned about that area growing bigger and the accountability diminishing? So what would work is the kind of question.
So we would like to see a board level officer at ICB level that's responsible for patient experience, that has accountability at that level. We know there are a lot of patient experience surveys out there run by various different organisations, CQC, the Friends and Family Test, the GP Patient Survey, and there is an opportunity here to try and bring and centralise those surveys into one area so there's better read across. And then we could do more in that area. So we are currently thinking about what it would be like to put a patient-centred metric at the heart of the NHS, so that culture shifts, so that patients are actually seen and their outcomes are seen alongside things like the 18-week target and A&E 4-hour wait. And we think that could really shift the culture so that the patient experience is at the centre. So we are quite reassured. We know West Streeton is very focused on patient experience, very focused on ensuring that the NHS is patient-centred. So there are some strong opportunities here. I would add one of the barriers is still around how the VCSE connects into ICBs. They've still been struggling to do that. There's not a clear mechanism, for example, how a respiratory VCSE can connect into the respiratory team in the ICB. And that's still not really been ironed out. So again, with another 50% cuts and the transition from NHSE to DHSC, that could worsen.
Okay. Thank you. I'll hand back to you, Chair.
Thank you, Dr. Becky Cooper.
Thanks so much, Sharon. Thanks very much for being here. I just want to follow up on my colleagues' queries around patient safety. And just see if I can get a clearer idea about that. So when there was the mid-staff scandal, the inquiry found that restructures of the NHS services can create risks to patient safety. Now, NHS England wasn't responsible directly for patient care, but I wonder, with your expertise, whether you could comment on where the risks potentially are, and whether you get a clear sense of how the department can help mitigate against those in partnership with obviously the ICBs and the rest of the healthcare service.
Yeah, so when it comes to the events around mid-staffs, I think there was a clear kind of concern about the relentless focus on finance and productivity, and that, you know, the voices and views of patients and families and of staff were not listened to, and because of that lack of responsiveness, you know, horrendous effects were had, causing enormous harm to patients and death. And so, you know, one of the things I would like to point to is around how we're changing that culture. And with Martha's Rule, which is a pilot which has been running for the last year, and I've given the committee members an example of how many parts of the system need to work collaboratively together to make those changes happen. And, you know, what's been fantastic around this is that the engagement not only of family members being able to escalate concerns, and we've had over 2,000 calls which have led to more than 300 patients having an improvement in their care and over 100 ending up being escalated to ITU or equivalent. I think it really shows that the patients and families have really valuable information that we can listen to. And if we act on that, then we improve safety and we reduce, you know, harm to patients, but also we improve things like staff morale, reduce numbers of complaints, etc. In my previous role, I was a National Guardian for the NHS and set up Freedom to Speak Up on the wake of the Francis report. And one thing I can say for certain is when change happens, people want to speak up. So I would really encourage all of those, whether that's in NHS England or in ICBs or in providers, to listen attentively to what their workforce are saying. And I know you're going to be hearing from workforce representatives later this morning, but also to be really acutely listening to what their patients are saying.
For the benefit of those at home, can you describe very briefly what is Martha's Rule and what we're seeing in front of us? Because we can't show them, so if you could just very briefly describe it.
So Martha's Rule is an initiative which was started after the tragic death of Martha Mills. And it's about giving patients and families the opportunity to get a rapid review if they're concerned about deterioration of the patient. It's been piloted in 143 hospital sites, and it's about giving the staff the ability to act on their clinical judgment, but also for patients and families, if they're concerned that they're not being listened to be able to get a review from a critical care outreach team. So this is something which I've been chairing the oversight group for this for the last year, bringing together dozens of organisations who've all got a really important part to play as representatives, as patient groups, but also for the professional regulators, officials, and the team at NHS England that have been leading the pilot.
Which is fantastic. So that's really helpful, thank you. And you'll forgive me, but having been in sort of the health arena for 20 years, and I'm sure you guys have been there for quite a long time, none of this is new, what you're saying. It's all sort of, it's been around in various forms, probably for longer than 20 years, about how we listen to patient voice, how patient safety is very important. So I just want to go back to a phrase that I think, Sharon, you used around organisational memory. So with this reorganisation, in terms of patient safety, in terms of the duties that NHS England has, how is that organisational memory being passed on? or do you think we are in danger of reinventing a wheel again?
So we would absolutely urge not starting from scratch. Obviously, this committee is sitting before Wes Streeton speaks on the 8th, so he may well have a clearer transition plan, but we urgently need to know what a clear transition plan looks like. We need to ensure that the day-to-day is being done in that 2 to 3 year period, 2 year period where the transition will happen. And with regards to patient safety, I think you're right, we hear stories of care going wrong all the time. I mean, the one thing for mid-staffs, I think, to highlight is that although ICBs are facing a similar environment in terms of finances and push on elective care, there is a better patient experience landscape now in terms of collecting information. So the Friends and Family test came out of the mid-staff's review. It's not perfect, but it is a mass collection of people's experience of care. If I was to advocate for anything, in NHS England, they used to have a clear directorate just for patient experience, and then it got subsumed into the nursing directorate. There's an opportunity here to put a directorate back that leads just on patient experience to show that it is really, really important. Again, going back to that idea of accountability at an ICB level. But just one warning, we've absolutely got to ensure that we're hearing from a diverse community. Health inequalities are essential to the Labour manifesto, and also it's a core function of the ICBs. So we've got to be really careful how we listen to patients. So, for example, we've gone out as National Voices to do some focus work on translation issues, and we had to go out into grassroots charity communities and hire a translator, an interpreter, to really understand their concerns. So doing everything online or doing everything on an English-focused app is not necessarily going to be the solution to hearing from concerns from everyone.
That's fine. Thanks, Chair. Thank you so much.
Robertson.
Thank you. Thanks very much. What sort of impact assessment would you expect to see from government for the reorganisation or merger?
So, to come in first, it's the health inequalities aspect that really worries us. We've spoken to various members, and we've gathered some evidence of where their concerns are sitting. So, Groundswell is a charity that focuses on homelessness. They do peer advocacy services across 11 London boroughs. They're worried about there's ICB cuts and whether that will be continued. We are hearing of recruitment freezes in clinical networks, which enable stroke victims, people of stroke, to receive vital rehab. Mind, the mental health charity, said that they are hearing that the cuts in ICBs are likely to be equity focused. Transactional, which focuses on healthcare for trans people, are worried that the shift to DHSC will make healthcare more political around the area rather than evidence-based. So I think there is a really, and also just to add, the LGBTQ health team sits in NHS England as well. So I think there's a real issue around how health inequality is being listened to and assessed. So that would be where our main focus would be, because we do know that Labour has a commitment in its manifesto to reduce the gap, the life expectancy gap between the poorest and the richest. And so we would very much argue how that will be achieved alongside this transition.
Yeah, thank you very much. We published the patient safety principles last October, and these after a public consultation, and these speak not only to identifying and mitigating health inequalities, but also a focus on equity, because we know that equality is not sufficient. We have to aim for equity. But the principles also set out a way for senior leaders to make decisions from the patient's perspective. And we know that's something that hasn't often been done in the health system, as much as people will create an infographic putting the patient at the centre. As a GP, I know very much that patients have to, work around very complex systems. And as Sharon was saying, that we need to include the views and voices of the widest range of people to ensure that we create services which work for the most vulnerable. On Monday next week, I'm publishing a report looking called The Safety Gap, looking at the needs of people with sensory impairment, so vision loss and hearing loss. These are huge numbers of patients who really struggle with safety in terms of their medicines and medical devices, but we also know that they don't always get a voice at the table. And so I think that the approach in terms of the 10-year plan has been very broad, it's been very deliberative, and it's then how is the system going to be ready to deliver on those plans, and how will the responsibilities at ICB level be enacted if there's going to be a reduction in their headcount?
It seems to me there's two sort of elements of an impact assessment. One is, what does the new reform department look like that emerges, and an assessment around that. So how does that differ from what we currently have? But also just the impact of a disruption, full stop. It doesn't really matter what the disruption looks like, but it's such a massive organisation that sits at the top, and with the staff cuts as well, that it needs to sweep both of those things up in an assessment.
Yeah, so what I'd really like is that we start with a focus on outcomes, and then we work back from outcomes to understanding what structures are required, what teams are required, what roles are required, and then, in terms of the people. And I don't discount the impact this has on individuals who are fearful about their roles being at risk, and how that in itself can, be very impactful on morale. It can be very impactful on people's, optimism about being able to function in the future. I also think that we have to look at the very broad context of this. These are big changes being proposed in the context of the 10-year plan and of the DASH review. And so there is very much something about ensuring that, we have that absolute focus on the needs of patients and service users and families and communities, and then the system has to adapt and design itself to be able to meet those needs, rather than, shoehorning something in that will then have a negative impact on patients at the end.
Given that the reform of NHS England is only one part of the government's plan for changing the NHS, albeit a big one, on the flip side, is there a risk that this sort of fills up that whole space of thinking about reform, and actually too much is pinned on the difference that structural reform will make at the top, and you can come out at the end of it with no better or no worse patient outcomes, and actually you can improve those things regardless of what sits at the top of the whole structure? Is there a risk there?
So I think one of the concerns is, how do you deliver cuts in ICBs by December of 50% on top of 30% already asked for? Transition NHS England into DHSC and ensure that the staff remain during that transition. So just to be really clear, at National Voices, we empathise with our NHS England colleagues about the way the news was delivered. We had many calls from people who were really shocked and really upset, partly because it's on the back of a reconfiguration that happened just 2 years ago. So how do you do that while also trying to deliver the 10-year plan? So I think one of the concerns we have is moving to the neighbourhood health teams is a good idea. It helps think about how you can develop prevention in communities. It helps to think about how you can reduce this reliance on acutes and ensure people with long-term conditions are better supported to understand their own health and manage their own health with the support of the NHS. And it feels a very big stretch to try and bring in these three shifts from digital, health, hospitals, community, and treatment prevention, while also trying to deliver the transition. So the concern really is a disruption around that. But also just really basic things like the day-to-day stuff. So we have a charity called Mind that's told us that everyone in their ICB that they work with has been told they're up for redundancy, that people aren't answering emails, and it just feels like, at the moment, chaotic. Obviously, that will settle down, but I think I agree with Henrietta, it's about focusing on the outcomes and building from that, which is, I believe, what the 10-year plan will look like, but how do you do that while also going through these kind of seismic changes?
Thank you. Well, as you mentioned, Sharon, we've got West Streeting in front of us on April the 8th. So if you had one question for West Streeting, I'm not promising we're going to ask it, but if you had one, what would it be? Can I start with Henrietta?
Well, I think that the centrality of the patient voice, as Sharon mentioned around the Patient Experience Directorate, there's definitely something about bringing that into the absolute heart of not only decision making, but also the organisation that does. The organisation that does, in whatever form it is, the mindset shift, that focus, and also the measurement of how patients are experiencing care, I think is a really important one, and that's what I would be calling for.
Thank you.
Similarly, we know that he's focused on patient experience, so how would he provide reassurance that in the current financial difficulties and pressure on patient access, patient experience remains at the centre of the mission for this government, so that the NHS is focused, as he said, on patient outcomes rather than getting bogged down in a transition period.
Thank you very much, both of you. Right, we'll move to the next panel.
Thank you.
Thank you so much. The cameras are still rolling, so just so you're aware. We are not shutting it down. This came out really strong. Welcome very much to our second panel, where the focus we are hoping is going to be on workforce, at least looking at it through that lens. Similarly, as I did for the last panel, may you please introduce yourselves and what do you do? Can we start with Jeanette Dickson, please?
Yeah, hello, I'm Jeanette Dickson. I'm the chair of the Academy of Medical Royal Colleges, which is the umbrella organisation for all 23 medical specialties throughout the 4 nations. We come together to talk about those cross-cutting factors like education and training and workforce. I am immediate past president of the College of Radiologists, but I'm also a practicing clinical oncologist.
Thank you very much, Professor Nichola Ranger.
My name is Nichola Ranger and I'm the General Secretary and Chief Executive of the Royal College of Nursing, representing over 500,000 nurses and nursing teams.
Professor Phillip Banfield.
I'm Phil Banfield. I'm chair of the BMA. I'm a working obstetrician still, so I'm delivering babies at 4 o'clock in the morning. And we represent now, nearly 195,000 doctors.
Thank you very much. We'll start with Greg Stafford, please.
Thank you very much. The government has said it's going to cut the total number of staff at NHS England and Department of Health by 50%. What impact do you think that might have on frontline services and the staff that work on the front line?
Yeah. I mean, the immediate response is that I'm not sure it would make any immediate difference to the front line. The front line feels that those running the NHS, whether that be NHS England or the Department of Health, so the politicians have become too detached from that front line. That also is how it feels if you're on the shop floor in terms of your trust boards, for example. So in daily, what does it feel like on wards and clinics? Probably not going to make any difference.
And if I will come to you in a second. I suppose my question there, well, I suppose there are 2 parts of it. Is what you're saying that you feel that currently you could cut 100% of the department and NHS England and the frontline would feel no impact, or is it about reallocating what those 2 organisations or a combined organisation does to make a bigger impact on the frontline service?
It is. I mean, the front line feels that what it needs is to be facilitated and enabled. So reallocation of those functions from NHS England or Department of Health to enable doctors and nurses to get on with the job is what is needed. So, it's not a case of cutting that expertise. You need to retain that expertise. The most obvious way of expanding that to the benefit of both the front line and the population is to invest more heavily in public health medicine.
May I come back to you, but carry on.
Thank you. At the moment, the Royal College of Nursing represents nearly 4,000 nurses and nursing teams that work in NHS England and ICBs. They're not bureaucrats, they are clinical nurses that run all sorts of brilliant services for patients, safeguarding, infection control, nurse leadership. So what we would say is we do not want, every nurse at the moment counts in the UK, we don't want to lose that expertise. But what we do also recognise is at the moment, as Phillip has said, it's really tough for anyone actually delivering patient care. And what we do think is understandable, that the Secretary of State is bringing that level of accountability back up to government. And let's be honest, the NHS is in a really difficult place, both for staff and patients at this moment in time. So actually, that level of accountability to improve what is a really challenged environment for everybody working in it is key. So we can understand that level of focus.
Are you confident that the changes proposed will increase accountability, or do you have a fear that maybe we'll replace one bureaucracy with simply a new bureaucracy?
That's what we can't do. At the moment, let's be honest, I was listening to how tough it is for patients, and we all know that. You know, we did a report earlier this year around corridor care. That is a symptom of a failing system. So what we can't do is have a big reorganisation that then never gets anything better for staff and patients. So, and that is the difficulty sometimes with a reorganisation. People understandably think, what does that do for me? And we've got to mitigate that human, genuine understanding with actually we are in crisis. We had a really difficult winter. Things are really difficult for patients at the moment. We've got big issues that require laser focus, and that is what has got to be mitigated against. We cannot have the focus on reorganisation has got to be done ethically well, people at the centre, but the patient and the task in hand cannot be distracted by this. And we know from experience that big organisations can be distraction from the fundamental things, and that cannot happen, particularly at ICB level, who are the key commissioners for getting people out of hospital into their own homes or where they need to be cared for. And the 50% reduction cannot come at the expense of patients. So I think this is going to take real skill to do wisely.
Thank you. Professor Ranger.
I think I echo what's been said. Absolutely, the folk on the front line want to do the best care for patients, and what they want from the centre is that enabling function to allow them to deliver that care. I think it's really important that we don't lose sight of some of the sort of slightly unsexy things that absolutely need to continue unabated in the background. So, for example, medical recruitment to training posts, training of all staff, IT connectivity and the work done to deliver that, cyber security, which is a potential huge impact on patient care, all those things that the centre do at the moment that need to continue whatever is going to happen. But I think I very much take your point at the end. What needs to come out is something that works better than it does at the moment, not just a slimmed down version of what we have. And going back to what Henrietta said earlier, it's about the outcomes. If we look at what the outcomes in the centre need to be and then build the functions around that, that's the best way to ensure that we have a fit for purpose organisation that enables the front line.
Thank you. And picking up on that last point that you made, obviously the rationale behind the supposed merging is to remove duplication within the two organisations, which I think most people would agree with. I think there's a potentially a lack of awareness that NHS England at the moment is not just a policy-making organisation. As you've mentioned, it's probably one of the largest and most complex IT providers. It's a massive training provider, and it doesn't provide the training itself, but it manages it. Improvement programmes run out of it. So I'm trying to really get, do you think within this merger that those things that perhaps maybe we can all agree are benefits to the system if they work properly might be lost or diminished, and what impact that might have if they are?
I think by recognising that those things exist and that they have a benefit, rather than saying, oh, well, we need to take out 50% and it's across the board, you need to look at every function of itself and everything that you as I say, you said, there is a concept that NHS England only does policy, but it does all of those other things that are absolutely critical to maintaining the frontline patient care and to improving that and to developing that and to changing that. And it's important that those functions are forensically looked at and decided what they should be, and the new organisation is tailored to deliver that with the expertise of the clinician there.
Thank you. Professor Ranger?
Yes, I think I think there are things that are going to have to, that are at risk of being lost, and I echo what was said about workforce particularly. We know we've got a big nursing challenge. We've got a real challenge with regard to the nursing profession, both in recruitment and retention. And I think that has not been done as well as it needs to be by anybody at the moment with regard to nursing. So I think there are some functions that do need to improve and remain. But I am genuinely worried as well, though, about the environment that we're currently working in, because it isn't just NHS England that are saving money and ICBs, it is providers. And Dr. Cooper, you brought up earlier about mid-staffs. We know that one of the big challenges for mid-staffs and that Sir Robert Francis's review was about nurse staffing. And at this moment in time, it isn't just NHS England and ICBs being asked to make savings, it's coming to providers as well. And I know posts are being looking at to take frontline nursing out. So there's a real danger that put all of this together and that we end up with a real risk. It's going to take real skill to get this right.
Thank you. I mean, I was shocked by the announcement, but not surprised at all, because doctors have been telling us for a long time now that NHS England's lost the plot over workforce planning, training bottlenecks, not listening about physicians' associates, its response to the latest Royal College of Physicians exam debacle, and the training bottlenecks at a time at which we need, for example, more anaesthetists. There are people wanting to train as anaesthetists, yet the number of training places are artificially restricted. I mean, it's just bonkers, the disconnect between what the need is and the ability to train. So, that needs to be replaced with something that delivers what patients need.
So, looking to the potential opportunities then that some of you have touched on, what few specific things would you like to see that comes out of this review, out of this merging of the two organisations practically, that would make lives better for people, for staff and patients?
I think for me it follows on from what Phillip said. I think I think there is no NHS without its staff. And I think a real look at what patients actually need, not just on affordability, but what the needs of patients are, and how do we both recruit and retain brilliant clinicians. And I think that is not where we are at the moment. I would think there's a real opportunity to do something different than we are doing, that puts, particularly...
So just to push you, but practically what?
So I think we don't look at exactly what Phil was describing around what's the acuity and the dependency of patients. So, for example, if you look at mental health, the way that we train nurses is we separate physical health and mental health. The reality is the mental health and physical health is completely merged together in many settings. This is an opportunity. How do we really train and educate nurses for what the patient need is at scale with the right calibre of people and look after them. So it's things like that, looking at population health. What kinds of clinician do we really need for modern day medicine and nursing?
Thank you. Dickson?
I think, I don't disagree with anything that's been said. I think there's a lot about, again, those functions of how do you retain staff? How do you make staff feel valued and do the basic things like pay them on time when they start, pay them at the right banding, if you are cutting out, for example, 50% of HR. So it is, how do you signal the value to people of being an employee, of being someone who delivers frontline care in a very pressurised environment to patients by valuing the staff, and that includes how you retain those staff. I think there's a lot of very good practice. I'm clinical oncologist. We work very much in an MDT function, but there is also, for example, sexual and reproductive health in the community, delivering care for patients, for women where they need it. Those exist now. It's how we then bring that out as being the model that continues.
Banfield?
So there are three really quick fixes. One is to fix general practice. I mean, without NHS England stopping contract reform, Right? There's an opportunity to have general practice, which is the most effective and efficient part of the health service. You've got this complete paradox where you've got over 1,000 GPs either under or unemployed, and yet one of the biggest patient complaints is I can't get to see my GP. How bizarre is that as a situation to be in? Secondly, use public health. Right? Public health was fragmented by the 2012 Health and Social Care Act. Get that back in front and centre. If you want to know how to reduce health inequalities, what is effective across your health service, really get the public health expertise invested in. That will cut through all the different agendas, especially if you give them an independent voice. And then not just train your workforce, but retain it, valuing the staff. You cannot expect people to care if they don't feel cared for themselves. Now that's about a top-down philosophy, but it's listening from the bottom up.
Thank you. I mean, I think you've all given me relatively broad, nice to haves. I'm not sure I fully understand what it is you think NHS England, Department of Health, whatever it's going to be called, merged, would actually do. So maybe I'll ask the question in a different way. What would you say is the primary purpose of this new organisation? Anyone?
I think it's to deliver, I think it's to enable frontline staff to deliver the best care for patients by doing the things at the centre that add huge value at the centre, like, for example, a strong overview of training and medical recruitment, like the IT connectivity, like all of those central procurement of IT, central estates management to allow the best value for that. It's the stuff that you do at the centre that enables the centre, that adds value to the frontline clinician, and then devolving to the localities what they can do best.
Can I summarise that to be the stuff that no one else can do and the stuff that no one else should be doing? Is that a fair summary of what you've just said?
I think other folk can do it. You can have local procurement, but it's where that central thing, where it should be done centrally, where it should be done to get that uniformity, to get that basic level of connectivity, of IT infrastructure that allows seamless movement of patients between primary and secondary community care. So it's what should be done at the centre is the stuff that the centre can do the best.
I'd like the centre to really focus on key performance around getting people out of hospital and into other areas. That shift of community, getting people out of hospital, and really focus on those measurable things that, because I don't think we focus a lot about the front door waiting times, but there are patients that wait an awful long time to get to another environment, and you don't get the sense that there's real grip on how long people are waiting.
Are you talking about social care right now?
Yeah, well, I think it's social care and community. It's both. It's district nursing, it's packages of care. I've been listening a lot to social care providers and other community providers. They're all saying that there's capacity. It's about commissioning the right things in the right funding. I think if there's just focus on that shift, it would make a very big difference to hospitals, because a lot of it, they can function. It's the 30% of people that don't need to be there. And at the moment, it's not clear who's really driving that. I don't think it's clear.
And your view is it should be this new organisation? They should be the performance manager of primary care trusts, and hospital trusts, mental health trusts, and community settings, and social care.
I think there's a real sense of people want local ownership, which I understand. But at the moment, we are in a real crisis. And the experience is if you need a bit of central grip and focus before you have local development. That's a personal view, because experience has shown us that. So there is something really important about, if it's pushed up to the government, what key things are they going to do with real focus and investment, because some of it will take investment, that we start to get the change. There is a danger that it all gets a bit devolved too quickly without, I think there's got to be connectivity between local and central, to get this right?
It's not clear to me who actually runs the health service, who's responsible for the health service. You know, it's a high stakes announcement, because now Secretary of State and the PM are clearly now responsible for delivery of healthcare in England. Austerity has led to poor health, but someone will need to decide what is provided and what is not going to be provided. That needs central direction and an honest conversation with the public. We will deliver whatever you ask us to deliver, given the right tools and resources and staffing and beds to do what you ask us. If you don't want that done, then don't try and commission it, because what we've been doing is we've been doing too much with too little, and that's led to patient harm.
I shall leave it there, because I'm sure other colleagues will want to pick up. Thank you very much.
Thank you very much. Josh Fenton-Glynn.
Thank you. I'm mainly going to come on to staffing, but just before I start, I was listening to quite a lot of your discussion that a lot that's done in the centre now shouldn't necessarily be done by NHS England or the Department of Health. So I'm just going to quickly go along the panel and say, can you all name one thing that's currently done in the centre that you don't think needs to be done anymore after the reorganisation? Janet?
I think what you need is a local performance management that isn't centrally driven, but it is responsive to local needs.
Nichola?
I think there is something around having that local sense of what. I think I do come back to workforce. I think some of that needs to be maybe a little bit more independent to see exactly what's needed for patients rather than affordability. I'd like to see workforce done slightly differently.
The workforce plan should be regional workforce plans, not a national one.
I think it's going to have to be both, but I think there is something about it. We know that when it's managed centrally, that there is. I understand cost, but I think we don't always look at what we need. I'd like something separate and slightly different.
Well, I mean, at the moment, NHS England collects vast amounts of data that is duplicated by the department, but it's not converted into information that means anything on the front line. So it doesn't. That could be lost with very little effort to make sure that any bits that are missing are provided elsewhere. But a number of the functions that NHS England do currently can be done within a public health setting. So screening, specialist commissioning, that can all be done within a public health model.
Okay, so moving on to the kind of the meat of my questions. The Secretary of State thinks this process is going to take 2 years. I guess what I'm interested in is how do we protect the front line and the staff at the front line from being distracted by kind of what's buffeting along the broader health service changes during that 2-year process. I'm going to start with Professor Ranger, if that's okay.
I think at the moment, for a lot of people on the front line in hospitals, in organisations, the NHS England and department is one step away from them. I think it won't necessarily affect their day-to-day lives. What they are worried about at this moment is the absolute savings that they're being asked to make within their own services. I think they would be less worried if it was just NHSE and the department that were restructuring, but they are being asked to make significant efficiency savings across the board. So there is no one at this moment in time in the NHS that isn't having to really look at their cost base and worried about taking posts out. So at the moment, I think a lot of frontline staff, it won't feel like it directly affects them, but what is affecting them at the moment is the care they're having to give and in really difficult circumstances and now having to make further savings. So I think the entire system is going to be focusing on money.
Quickly paraphrase, your suggestion is that generally the staff won't be too worried about the broader reorganisation, but the drive to efficiency is something that you think is probably creating some anxiety.
Correct.
Okay. Janet Dickson, in terms of obviously associated with medical Royal Colleges, you have a very broad view of quite a lot of different specialties. I'd be interested as to what you think the changes to the national body will have, what impact that will have on the front line, and how we can best protect the front line from that.
I do echo what folk have said, that for many on the front line, NHS England and the DHSE are at one remove. What the front line really wants, and I hear what Nicola's saying, and I don't disagree with her about their cuts themselves, what they want is a centre that enables them to deliver excellent patient care with the least amount of interference. So it is about, for example, monitoring of data. How many times do you give the same set of data to 2 or 3 different places in a slightly different format, and it's not automated because you're not enabled for it to be automated. So I think looking to the future, the staff on the front line are concerned about the cuts they are seeing on the front line, yes. What they are concerned about is that future enablement, but also the retention of the things that need to happen that people don't think about, like medical recruitment, like training.
I'll come on to training in a bit, but just to test that a bit, you talked about you don't want interference. I just wonder, from your point of view, when accountability stops and when interference starts.
Phil talked a bit about the data. So all the data flowing into NHS England are not then flowing back to the trusts and the providers to say, and this is how you could improve. And this, we've used your data, we've taken your data, we've done this. We're helping you to say, this is where you need to focus. And I think the accountability is there because the data goes back up. You need to slimline how many data points you have. But you also need to make that data back to the trusts to enable that to be used in real time.
Can I just come back in there? What I found fascinating about the data is that was NHS England data that Lord Darcy used his report, the Darcy report. I felt that was a shame that it took Lord Darcy to kind of hold the mirror up to say this is the state of the NHS, actually, because that data was sitting there.
Yeah, I mean, what was interesting when we spoke to Lord Darcy, he said that often he kind of had to threaten to FOI it before he could actually get some of the data out. So perhaps there's an openness challenge for the NHS, and having worked on a large health service related survey in the past, I could probably recognise some of that. Dr. Banfield.
I know I work in Wales and we're talking about England, but I would have spent my entire 30 years as a consultant without any usable maternity information system to give that immediate feedback about what we're doing and how we're doing. Who knows what will happen in this 2 years? I've never seen a reorganisation that is smooth, cheap, or that works in the way that it's supposed to work. But I do know that we have an immediate need on that front line, not just about waiting lists, waiting list targets, but the hidden waiting lists of mental health, child and adolescent mental health. You cannot get away from that elephant in the room about social care, of freeing up beds. If you're not going to give us more beds, you need to free them up. But also recognising, the immediate is Secretary of State talked about the NHS having more pilots than the RAF. We are expensive experts, all right? And we need to be used to allow that expertise to be applied to the patients who desperately need it, rather than us doing other things at that time. So that can be facilitated while any transition goes on. There's nothing stopping that from happening.
Okay, I'm going to now quote directly from you, Dr. Banfield. You said, let me find the quote, sorry. He said that retaining appropriate expertise during the reorganisation will be vital to, quote, the coming battle to mend the NHS. What particular areas of expertise are needed to be retained in the kind of central function?
Well, I mean, you've got, certainly the specialist commissioning services, and that might go from rare cancer services to kidney dialysis. You need to retain that expertise that we do have in public health and expand it. We've got expertise in different specialties, and I'm sure the colleges will do more and help more, make sure that the specialist expertise is looked after and enhanced for the benefit of patients. I think that there are screening programs, immunisation programs. These need expertise that has to come across. And I mean, there are lots of examples. There are 1,500 plus doctors and dentists who are, may be affected by this. No one wants to see people's jobs at risk. They have an expertise that we lose at our peril.
Thank you. I'm going to shift quickly to training. So Health Education England was merged into NHS England about 5 years ago now. And that means that the responsibility for staff training and education will sit in the Department of Health and Social Care. To what extent is it appropriate for that to be delivered from the DHSE? And is there an argument for keeping some of those responsibilities kind of at arm's length from the government? Obviously, that goes to Jeanette primarily.
I think there is a tension always between training, and we're mainly now talking about postgraduate training. So we're talking about doctors who are qualified and nurses who are qualified. HEE was a multi-professional educator. It educated doctors, nurses, radiographers, pharmacists, who are qualified and working as doctors and therefore delivering frontline patient care, but are being trained to become independent specialists.
I think one of the things that I most wanted to get across to the public when I worked at the GMC is that most care you receive in hospital is from some level of trainee.
Yeah. Yes. And those trainees, resident doctors, are at the moment concerned about their job prospects, given some of the stuff that Phil has spoken about, but there's also things such as an expansion of medical school places. The fact we know we have areas that are significantly under-doctored, and the population of people who are funding the health service are not receiving the same care. So it's about how we utilise that national view of education, I think, to make sure that there is training opportunities and training happening in every area of the country, not just in the attractive, or what we would call attractive to certain groups, areas of the countries. And I think that's why I would feel that some of the functions of a central education system work really well, because they can have that overview of where are the needs for other healthcare professionals to be trained, but also it has a longer view. It's by definition a 5, 10, 15-year view of what medicine needs in the future and can deliver the healthcare training for that future delivery model, which is very different to today.
I'm going to go Professor Banfield. Do you feel that a centralised training with a kind of broader look at the health service would be a better model moving forward?
Look, I do. I mean, it's the same pot of money that says, here is the health service, these are the professionals that we need to train for our health service, and yet we then fragment it by saying, the medical schools council and the universities will get this pot, and the Royal Colleges will talk about what the postgraduate training will be, the GMC will oversee that, and it's not joined up to actually how do you get a doctor or a nurse in front of a patient. So there's an opportunity with one layer removed to improve on that and to focus on what specialties where your deficits are. And that's, that to a certain extent, that is a political decision to make. You know, if you invest in undergraduate places, you have to invest in the academics who are going to train them after that. You know, you can't just plop 10,000 new medical students into the system if there are no jobs. We've already got to a stage where a significant number of the students qualifying this year with 100k of debt don't have knowledge of where they're going to be in August. You know, that's a ridiculous mismatch of planning.
And a huge reliance on AMGs in the system as well.
Well, you know, the Nuffield Trust has just published that we have an over-reliance on red list countries. So, you know, we are bringing in doctors from overseas, promising them training that we can't deliver, when actually what we want is we want them just to staff our hospitals, and that's, you know, needs much better focus about what the future should hold.
And if more care is to be delivered by SAS level doctors, then that's a different debate we need to have. Sorry, I'm conscious of time because I'm sort of at the end of mine, but I do want to check with, go to Nichola. We were talking about medical training.
I mean, I
yesterday.
think we desperately need something very, very different. We've got no faith in the non-NHS workforce plan that talked about increasing undergrad, nursing. At the same time, last summer they made more nursing tutors redundant than ever in my lifetime. CPD for nursing is not ring-fenced, so at the moment it could go into the bottom line in ICBs. Nurses are desperate for postgraduate education. It's not ring-fenced. We absolutely need to change that. And Dr. Banfield's view was absolutely right. We're so reliant on international nurses. 50% of the NMC register this last summer was nurses internationally. And with the focus on...
Just quickly, is that all registrants or new registrants?
New registrants. So it's now 33% of all registrants, and it was 50% of those qualifying. And with the potential cuts and potential reduction in vacancies, we are already worried that students graduating from nursing this year are already worried about whether they're going to get a job. That is a disgrace, so it's got to be changed.
Thank you all. I'll hand back to the Chair.
Thank you very much. Dr. Bucky-Cooper again.
Thanks so much, Chair, and thanks everybody for coming along. I should declare before I start asking my questions that I'm a member of the BMA, but Professor Banfield's, endorsement of public health, I've not bribed him to say that, so that's good. But I do want to talk about public health functions. I do think that there are many questions around public health and the implications of the reorganisation for public health. So I know the BMA has said that it has got concerns around the public health functions and the public health workforce. So just for the record, I think we should probably just point out that we had Public Health England, and then that splintered into the Health Security Agency and into the Office of Health Inequalities and Disparities, or Improvements and Disparities, and then the local authority function as well. So we've got that splintered makeup now. So I wonder, with your areas of expertise, if you could talk through the opportunities that merging DHSC and NHS England potentially bring for public health, particularly in that area of health inequalities, because we heard from the previous panel that was an issue, but also the risks that it brings to public health. And perhaps if you want to talk about the budgets as well, that would be really interesting. So shall we start with Jeanette first, if that's okay?
I think we all recognise that public health is the key way to improve the health of the nation going forward. That primary, secondary prevention, all of the health monitoring, but also all of the screening things. And as you've quite rightly pointed out, they've had a very rough ride recently and a lot of changes. And I think it's incredibly important that part of the discussion around, there's a 50% headcount, we need to be absolutely clear about what, as I said before, what functions we want from the centre, what functions we need to be at the centre, and what that outcome looks like, and then build back the number of staff that actually needs to take it.
Just to be clear, Jeanette, do you think that the OHID should still remain in the centre as part of the Department of Health and Social Care? So that health inequalities and disparities piece, do you think that's best served in the centre?
I think I would defer to my public health colleagues on that, because I think there are pros and cons of everything, but I think it's about understanding the function needs to exist somewhere with population-based oversight and national population-based oversight. There's lots of different locale stuff, there's very much place-based stuff, but there is that national oversight needed.
Thank you. Nichola, Professor Ranger.
Yes, I mean, I think, where public health sits, obviously, is with the experts. But I think there's something for me around, we know since like 2009, some of the key people for public health are people like health visitors, school nurses. They've reduced by 45% since 2009. They're crucial for those people in where communities are. We would love to see it incentivised, that some of those numbers go back up to that 2009 figure, even as a start. And we would like to see, nurses are the constant 24/7 presence in many areas. We would love a real focus on prevention and public health as part of their day-to-day lives and work. If we could just find a way, both as a profession, which we can do, and externally, to liberate nurses' time, they're a really good army of public health.
Absolutely.
Committed people.
And perhaps if I could just reflect something of what you were saying earlier around the current bizarre training programmes for nurses where mental and physical health is separated. Would you see the public health function of that sort of more holistic training sort of very much being part of that redesign?
I would really like us to do it, and we're looking at that as a college. I think things are far too segmented. You've got one person in front of you with so many different needs. You need someone skilled that can assess what you need both now and in the future, what the problem is now, and I think we need to relook at the nurses that we are educating to really put the person at the centre. At the moment, though, I'm afraid nurses pick up too many jobs that other people don't want. They have too much bureaucracy. So I think in order to function as we want to for the public, we need to liberate their time in a slightly different way.
That's interesting. I might come back to that, actually. Professor Banfield, public health systems, where is the BMA?
I mean, look, COVID exposed just how fragmented, how dismantled public health had become. So splitting, a big chunk of public health away from the health service, we wasted billions of pounds that we didn't need to spend, and more people died than needed to because of that public health not being in the state that it should have been. And this is just an opportunity to repair that.
How do we not waste billions of pounds this time?
You can use that. It doesn't matter what structure you've got. If you've got the people there with the function to take that big picture view. I mean, inequalities in the population, inequalities in the workforce, valuing that and appreciating that diversity, protecting a large number of the workforce have disabilities. That public health function can do that. Enormous amount of public health prevention work goes on in general practice, nurses in general practice as well. So this is a huge opportunity here to reset that.
Great. So if I can just move on with that thought, really. So thinking about that holistic health service provision and the staff and the staffing opportunities that are there as this new function develops. Professor Ranger, I wonder if I could come back to the comment that you raised earlier around nurses picking up roles and perhaps healthcare professionals picking up different roles at the moment. And I wonder if you could comment on perhaps the manager-clinician relation in staffing and how that works or doesn't work, and any thoughts as to how you think that might be more appropriately managed as we see the changes at the centre and ICB. So, Professor Ranger,
I think it's a really good time to take a really good step back and say what's good governance and what's bureaucracy. Clinicians are extremely good at knowing what they do that's complete and utter waste of time. Let's try and get people to work at the top of their licence wherever they are. We are quite risk averse, and actually to make a good patient decision requires a little bit of judgment and risk. And a lot of things is done by protocol, whether it's assessments, whether it's risk assessments, because people are scared of someone falling or not getting a DVT or whatever it is. So we're quite protocolized, which actually sometimes takes a lot of time. And some things are essential, but some things could be stripped out. And it feels to me like a good time to take a look at everyone seeing what they're doing now and what they'd love to be doing for their patients. And because I think we've got to work differently. And some of that is about risk and people being understandably defensive in how they practice, because actually it can be tough if you make a mistake, but that takes a lot of time. And I think that would free up clinicians really being able to do what they know is right for patients.
Okay, thank you. Jeanette, any thoughts?
I think management is not something that miraculously appears because you're a clinician. I think you really need to be trained for it, and you need to be trained well for it. I think there is an absolute value to having clinician managers because they see the full picture, the nuance of the sometimes unintended things that happen. But I also think that in many roles, this is not an incentivised role. It's not supported. You wouldn't in an industry take senior clinicians, ask them to do management and not support them, not train them, not support them, not provide coaching or whatever for them to do their best job. And most managers in medicine and nursing and the healthcare services generally, they retain a clinical role and flip in and out of clinical and managerial roles. There are a few who continue to be pure managers, but most flip in and out of those clinical roles, so they go back to being within their clinical group. So how you prepare that clinical group to be managed and to accept management and then to move on, I think is a really important thing that we don't focus on enough, I think.
Thank you, that's really valuable, and I suppose as the centre rearranges itself, it will be, as you say, an opportunity to perhaps revisit some of that. So my final query, and Professor Banfield, I'd like to come to you on this, is I am very keen on institutional organisational memory, and yourselves, you've been in this longer than I have, but there have been, as you've previously said, several reorganisations, and so I would just like to hear your thoughts about what lessons you would urge the government to draw from previous attempts to reorganise the NHS, particularly with regard to managing the impact on staff and staffing. So, Professor Banfield, I'm going to start with yourself.
Well, it's going back to basics, isn't it? Start defining what you want your health service to deliver, defining where your priorities are. Is it the elective service? Is it the emergency service? How are you going to transition from hospitals to community? So having that overall picture and then using the expertise that will help you get there, because sometimes you're going to need to speak truth to power. It's going to cost you more to do it that way. But what we need as a service and as a country is long-term ambition and long-term investment, not short-term kind of political papering over the cracks. But it's, fundamentally, this is an opportunity to change the culture of the NHS. We've heard this morning about patients and listening to patients. Now, that's not just about how your health service is organised, but when you're a medic, the doctor will tell you what's wrong. The patient will tell you what's wrong with them. So just listening to them, they'll tell you when what you're doing is wrong as well. But we're still in a system that blames the individual on the end of the mistake. We're in a safety-critical industry. Stuff goes wrong all the time. It is amazing the amount of harm and error that we trap every day. Right? So the making sure that the advocates of the system needing to learn are still in place, still being heard, because what we get, and there have been very high-profile examples, is we have an NHS that feels that it has to hide stuff or it has to look after its own bit of an organisation as to being open and transparent. And this is the opportunity to reverse that and to listen to the concerns of both staff, doctors, nurses, and patients.
Excellent, thank you. So a learning system sounds very wise. Just to pick up on, and you have said this a couple of times actually, about what the NHS is there to do and what we're there to deliver. So I think that's a fairly comprehensive answer. So do you, in your expert opinion, when you go to your respective jobs, when you speak to the people, are you very clear about what the boundaries are for the National Health Service in terms of what clinicians are there to deliver, how we are there to deliver it, or does it feel that it's an ever-expanding way? We're sort of, we're doing a lot, as I think Professor Banfield said, with not enough, and it's not clear where those boundaries are. I don't know if I've phrased that correctly. Does that make sense?
Well,
Sorry.
I may have misunderstood your question, but I think at the moment, I think what people need is a bit of hope, actually. And at the moment, what they are doing, they want to be doing well. And even if you extend out, extending boundaries, I think at the moment people just even want to be able to do the basics well.
Yeah.
And I think that is what this reorganisation has got to do. Patient satisfaction in the NHS is the lowest since we've measured it, actually. People are looking for more private healthcare than they ever have. Staff are a little bit fed up and demoralised. The best thing this reorganisation could do is start to improve on some metrics, even if it isn't everything. Because what people are starting to do is a little bit of faith in the NHS, both the staff and the patients. That will be a disaster. So whatever they decide to, whatever is decided centrally and with clinicians and providers, what needs to get better, let's get it better, because at the moment almost everything is struggling.
Yeah, that's interesting. Thank you. Jeanette, any final thoughts before I hand back?
Yeah, I think Nicola's got it right. Patients need to feel that the NHS will be there when they need it. The question is, we ration as we're doing already, we just are slightly quiet about it, and we're uneven about it, and we're inequitable about it. Mm-hmm. Can we deliver everything for every person in the population? No. Yeah. But how do we deliver the best care we can with the money we have? And that's about enabling clinicians to do their job by providing the basics, which is good staffing, good infrastructure support to do that, and a culture that learns and understands and doesn't blame individuals.
Excellent. Thank you, Chair.
Thank you so much. Well, just leaves me to say thank you to you all for being here today. Much appreciated. I'm going to ask you very quickly the same question I asked the last panel. We've got Wes Streeting in front of us on April the 8th. What very short question would you ask him? Phil?
Are you going to listen to the front line?
Thank you. Nichola?
Are you going to sort out the nursing crisis, because without it you'll fail?
Mm-hmm. Jeanette?
How are you going to ensure there's an effective clinical voice, clinical leadership in DHSC to ensure that patients benefit?
Exemplary. Thank you so much. Next panel.
All the same question.
We're here on our third panel. Thank you so much. Yes, do take off your lanyards. You don't need them. We know who you are now. So thank you. This is our third panel. We're going to be looking at broader structures, previous reorganisations, what lessons can we learn. So thank you again for coming and seeing us at such short notice. As I started with the last panels, may I invite you to introduce yourselves and what you do, starting with Matthew Taylor.
I'm Matthew Taylor, and I'm Chief Executive of the NHS Confederation, which is the organisation that represents all parts of the health service in England, Wales and Northern Ireland.
Thank you.
Morning everyone, my name's Siva Anandaciva. I'm the Director of Policy, Events and Partnerships at the King's Fund think tank.
Thank you.
I'm Nichola Timmins. I'm a Senior Fellow at the Institute for Government, which is a think tank that tries to make government work better.
Thank you so much, all three of you. We'll start with Danny Beales, please.
Thank you very much. Thank you very much for joining us today. It's been kind of reported that many health ministers and Secretary of States since the Lansley reforms have reported kind of frustrations about ever-increasing or perhaps kind of never diminishing levels of political accountability for the performance of the health service. Ultimately, election time, it's the government, it's the Secretary of State who's held to account about NHS performance. But kind of reporting frustration about not having necessarily all the levers of power to drive the change that they want to see since those Lansley reforms and the establishment of NHS England. How do you think that's a fair characterisation of the power and levels of accountability that exist and the balance between them? Kind of open up generally to the panel, whoever wants to kind of...
well, we could all talk for hours on that, so we'll try and restrict ourselves.
15 minutes per questioner. So.
I think you need to get to the root problem, and for me the root problem is over-centralisation. So it's not political accountability per se, it's the fact that the centre seeks to be in charge of too many bits of what is a complex and interdependent system. So, yeah, in a different world, in other countries, you wouldn't have this level of direct political accountability. People say to me about other health systems that things go wrong, but you don't blame the President and the Prime Minister. But in this country, we kind of do, and we almost take pride in it. But that's just the way things are. I don't suppose that's going to change. But if you do have that, then you really do need to try to focus on a relatively small number of genuine national priorities. And then you need an effective way of devolving power within the health service. And what that then requires is for you to have a system of incentives and rules that gets the different bits of the health service, because never ever underestimate the sheer complexity of the health service. So you need a set of rules and incentives that encourages people at local level to work together in the interests of patients. So those are the two things you need. A smaller list of national priorities and an effective way of devolving to the health service, whether we're talking about places or systems. We can get later into how it is, what structures might be the best at that local level.
That's I think a helpful summary of kind of the view of the system. So just to my point, do you think that currently we have, so your assessment is we have an overly centralised system with NHS England. What's your view about the potential change? See the assumption of some of those responsibilities, we don't know what level, at the Department for Health. Do you think that's going to improve centralisation or get to that right balance that you want to see between kind of discrete priorities and accountability for the system?
I think the merger itself is kind of largely irrelevant to that. Partly because what we're essentially seeing is the making de jure of that which was already de facto. And partly because it's not really about the relationships in the centre, it's the relationship of the centre to the service beyond the centre that matters. So yes, there is and there has been a growth of kind of duplication of functions, and there is real scope, I think, to reduce the kind of headcount and size of the central operation without any loss to anybody. But unless you address those core issues of a more manageable set of national priorities and an effective form of devolution, what happens at the centre, that's not the critical question.
Can I just come in quickly on the political accountability? So if that's how they feel, absolutely that's how they feel. But I've got to admit I'm a little bit confused, because when I read Nick's book, Window Breakers and Glaziers, about the history of health and care secretaries, when politicians need to step in, they step in. Whether it's removing leaders of NHS organisations or recalibrating the system, it doesn't feel like that political accountability has been absent, which I think is absolutely right. And politicians get the blame when things go wrong. So I absolutely accept that it could have been friction, that you have a political objective you want to achieve or policy objective, and there's friction there. But I really think I would be surprised if it was the case that politicians were trying to deliver change and the machine keeps saying no. So I guess one of the things I keep coming back to is that classic James O'Brien question. In 2 years' time, when NHS England is legally abolished, what announcements will you be able to make that you can't make right now?
Thank you.
You've answered my last question now, but that's great.
Nicholas,
I agree with all of that.
That's helpful.
I mean, basically.
So, I mean, Matthew, your kind of, I guess, fair challenge to the question. So, if the point is where the balance lies is the crucial part, empowering the system locally and then holding it to account on a discrete set of measures. What today that's done by the centre needs to stop? What functions of either DH, NHS England, or other aspects of the centre do you think, as part of this change, needs to stop?
Well, I think arguably if you're being critical, you would say that the centre has not sorted out problems that it could and should have sorted out, but it has interfered in things where it doesn't necessarily add a great deal of value. So there are frustrations that people have in the service around conflicting incentives, around the fact that the general direction of travel, which the Secretary of State speaks of, seems to be contradicted by the short-term imperatives of the system, that quite basic things like information governance are not sorted out. So there are things that the centre actually should do a bit better and a bit tighter, but on the other hand, the proliferation of things that the centre does has led to kind of great frustration in the system, and there is no question that NHSE did suffer from kind of mini empires growing up, and a kind of perplexing lack of joining up as a consequence of that. So, for example, you'd have one team of people working on the reform of urgent and emergency care, and you'd have a completely different group of people working on the future of primary care, even though primary care has an incredibly important role to play in trying to reduce unnecessary demand at A&E departments. So you would see over and over again, I would often meet people, talk to people in NHSE and have to tell them about projects taking place in other parts of NHSE which clearly impinged upon their role but which they didn't even know about.
It's a fair general point, but is there ever an aspect of healthcare which doesn't in some way deal with another aspect of healthcare? I mean, if you shifted that responsibility locally, would we have suddenly an integrated health and care system where all parts of the system planned and worked together?
So I spoke earlier about the inherent complexity, but I think the fact is at a local level you somewhat reduce that complexity because you're closer to the front line. You can get the key individuals who need to, for example, develop a new approach to urgent emergency care. You can get them in one room together. So it's always complex, but it's massively more complex if you're a long way away from it and you're trying to do something in 42 ICSs or with 200 different providers.
Yeah, can I just add something? I mean, and the question I would ask is, if you take all those points, why is primary legislation the answer to them? And I don't see that it is. Why? The question is, why do we need primary legislation? So you can take all the points that Matthew's made and others, and it's clear that the relationship between the department and NHSE has not been good for some time. It's all become a bit sclerotic. There is overlap, but it's overlap around policy and operations. There's a lot of other stuff that NHS England does that, IT, the improvement work it does, which there's no overlap there. It's just the sort of policy and performance operation where there has become second-guessing and overlap, and that needs sorting out. And the Secretary of State's been perfectly clear about that, and he's absolutely right about it. What does not follow from that is that you legislate to abolish NHS England when, as far as I can tell, no one has any idea what's going to be put in its place.
Did you explain?
Yeah, I just want to make a quick point based on what Nick and Matthew were saying. I find it really hard to answer your question without knowing what the new architecture of the system looks like. Because to answer what is the centre going to stop doing, you need to know, well, what is no one going to do in the new NHS versus what is going to shift to ICBs versus what is going to shift to provider collaboratives. And at this point in time, we don't know what the future state size of those organisations will be.
Yeah. Can I just drive the point home slightly more? I mean, the Secretary of State said in Parliament, I could do most of this without the legislation. And those with longer memories will remember that's exactly what Andrew Lansley said about his 2012 Act, and there are no fans for Andrew's 2012 Act. And he could have done most of it without legislation. He was absolutely right. So what is it that needs to be done that requires legislation? No. I don't know the answer to that.
Well, hopefully we'll... I mean, I think there's obviously quite more questions than answers at this stage. I suppose we're trying to get a sense from what you would ideally want to see from the emerging reforms. I mean, it feels...
I could just go one step further.
Just kind of build on it. Feels like you're saying kind of slim down, more focused centre, more emboldened kind of local leadership, which we hear is the direction of travel. In terms of how do we ensure effective accountability of the local leaders? Do you think at the moment, we've had a patient session earlier, representatives of patients, how do you hold your local leaders in this new system effectively to account for their performance if they're being judged nationally, at least on a very slimmed down set of measures by a more slim focused centre?
I keep going first. I'll go first one more time and then I'll stop. So just to reiterate what I said earlier, my view would be the critical determinant of whether or not this reorganisation improves things is whether or not the centre devolves. If the centre does not devolve, this reorganisation won't achieve anything. If it is a pathway to greater devolution, then we might look back on it and say this was an important and positive moment. So I want to be categorical about that. In terms of accountability, different types of the system need different types of accountability. I think what excited many people about the integrated care system model is that it offered the opportunity to balance top-down vertical accountability with greater local horizontal accountability. And that's very important when you're addressing issues like population health and health inequalities. As I'm sure the committee has heard from many people, only 20% of our health outcomes are a result of what the NHS does. So if you really want to improve population health, you need to work very closely between not just different parts of the health service, but with local government and others. And I think one of the critiques I would have of NHS England is that it was very focused on the kind of silo accountability within the NHS, particularly the accountability of providers, which is kind of fine, although often there was duplication with regions and systems in that regard. But it never really, I don't think NHS England got its head around the idea that it had created organisations that needed to also have the scope for lateral accountability, to work with partners at a local level. And because NHSE doesn't have a brief to work beyond the NHS, whether it's neighbourhood working or place working or system working, it just couldn't really understand what its role was if local partners wanted to work with people outside the health service. Now that is something that ought to improve with the department, because of course the department has responsibility for social care, so you've got a bit more of a link there.
Thank you. I guess my question was, how as a patient do you hold to account local leadership in a new system? At the moment, we hear from patients it's quite hard to navigate the health system. Obviously, we talked before in the earlier part of the question that ultimately the minister's seen as very accountable, but in your kind of ideal model of a slimmed centre, responsible, focused on a slim number of things, again, locally, I'm still not quite sure how. I can understand, I'm inferring it's kind of a trust-based system and a collaborative system that works better and delivers better outcomes. But if it doesn't, if there's local failure or failure of local leadership, how is a much more emboldened local leadership model held to account effectively?
Well, I have thoughts on that, but as I say, keep going first. So.
Very quickly, because we need to move on to the next questions.
Yeah, I guess until you asked the question, I hadn't realised something I was struggling with. And one of the things I was struggling with is, how do you get the current way of operating and holding to account and regulation working in a system where everything is broadly shrunk, both the people being held to account and the people doing the holding to account? And I guess part of the answer is you can't. You don't have that same model of accountability. There was a time when, it wasn't all wine and roses, but back when Monitor was authorising foundation trusts, that relationship was very, very different. You have a very slimmed down number of metrics that demonstrate good progress that are reported up nationally, and then you have a lot of local accountability through things like governors and members that weren't all universally working, but at least then you had a model of accountability that could work when you have far fewer people as part of that accountability chain. And the final thing I'd say is you also have other bodies like the CQC that play a hugely important role in assessing leadership and accountability of systems.
Fantastic. We heard from the previous panel about some of those core national functions, things that should really be done nationally, maybe healthcare planning or digital capability. NHS England was responsible, subsumed NHS Digital. Do you think those kind of core functions and driving the kind of rapid change we want to see around, for example, digital or workforce planning are going to be possible with the level of reduction in staffing and resources that are planned?
I think there's a real issue about digital. And this is one of the areas where there seems to be tension between the Secretary of State's vision, from analogue to digital is one of his three big shifts, and where the investment has gone in and where the capacity exists. So I think of all the issues you've quite rightly identified, one that I think is arguably the most concerning in terms of the vulnerability of the centre's capacity, and that is in the digital space, where the opportunities are enormous, but the capacity at the centre was arguably already insufficient, and now arguably will become even more insufficient. And I think one of the challenges for the Secretary of State is to say, how are you going to achieve your third shift, your analog to digital shift, with the capacity you've now got at the centre to drive that?
Yeah, I'll be super quick on digital. I think that is one of the key issues. So a lot of the talk about duplicated roles across NHS England and the Department of Health and Social Care are about policy, strategy, finance, HR, comms. Digital is one of those things where a lot of the history, the expertise, the national leadership of the digital agenda was housed in two bodies, NHSX, that folded into the Transformation Directorate of NHSE, and NHS Digital, that folded into NHSE. So I think you've got a first-order decision over what digital things are you going to do at the national level. Are digital leaders going to be subject to the same 50% cuts? And if they are, then what are you going to segment? Because there's one way of segmenting it, which is basically the hygiene stuff that makes sure electronic prescriptions flow, that there is an electronic digital record. And then what goes is some of what Matthew was talking about, the analog to digital shift. But also, and I'll finish on this, there are a small number of teams on things like cybersecurity, but also rolling out a new electronic procurement system. Those are low-frequency events for a healthcare system. So it makes sense to have a central team that does that. So I am worried that digital is one of those areas where you look at and you don't immediately see flab to cut.
I think my time's at an end. Apologies, but thank you. That's really helpful.
Thank you. Paulette Hamilton.
Thank you and good morning. My question is around the soaring costs. NHSE, as everybody knows, what was being said was the staff and admin costs had soared to over £2 billion. What they've also said is that NHSE, there was lots and lots of duplication. My question is quite a positive one. What savings do you think could be made with NHSE closing going forward? So as a system as a whole, with that $2 billion being saved, what actual savings within your different organisations do you feel could be made? But the question that's really is important to me is, do you feel it's realistic what is being said? And thirdly, do you believe it will actually make a difference? So is it realistic? Will it make a difference? And where do you think the savings will come from? So I'm going to give you a break, Matthew, and I'm going to start with, Nicholas.
Yep.
Thank you, Nicholas.
Right. Well, in terms of sort of mass savings, that's not going to make a hell of a lot of difference. I mean, the figures being thrown around is 500 million. That's after, the savings you will eventually get after redundancy costs for nearly 20,000 staff. In the NHS budget, that is a relatively small amount of money, so that's not going to be transformational.
Is it realistic?
Well, if you cut enough heads, it is, yes. And in terms of, sorry, the second part of your question was,
is it realistic, and will it make a difference?
Well, will it make a difference? Well, the answer is we will know when it makes a difference, when we know what it is, because we genuinely don't know what it is. I mean, is the proposal just to roll NHS England into the department wholesale, which it might be. I mean, you could do that. You've got 42 ICBs. There'll be fewer ICBs by the end of this, because integrated care boards at the end of this, because they're going to have to merge with the scale of...
We're going to come back to the whole ICB thing.
Yeah, okay. So you could just roll it all, in theory, I suppose, you could just roll it all into the department. But the point's been made that the areas where there is overlap and duplication that needs to be removed are relatively limited, around finance, operations, policy making. You're going to take the improvement programs like GIRF into the department and put them there? Are you going to take all the IT into the department and put it there? What about the NHS England regions, which do a fair amount of performance management? Are they going to be part of the department? Or are they going to stay with the NHS as a regional tier, in which case you're going to have to legislate to create them and decide what they will do? So lots of stuff flows from this that is absolutely unclear. So to answer the question, will it make a positive difference? Don't know, can't tell. That's not being obstructive. It's just don't know, can't tell.
Today is about getting your honest opinion, and that's what we're here for. So thank you for that. And I'll go straight over to Siva.
Thank you. So is it realistic? I think it is realistic to expect savings on the order of hundreds of millions recurrently. After you get through, we don't know what the exit scheme looks like, but after you get through that exit scheme, I think the two constraints on how much you can go at are, first of all, how much actual duplication there is. When you're bringing together one organisation that's 4,500 people and another that's 14,500 people, there's only so much duplication to go at.
So
overall.
do you personally believe that that quote around duplication is correct?
I think it's correct for some functions.
Right.
But it is simply illogical to say that two organisations are that duplicative when you have that many different functions, that different headcount. And sorry, the other bit of how realistic it is there are some functions that NHS England does that are in statute, so have to be done by someone somewhere. So again, there will be that 2-year transition period. I want to come back to your positive angle on the second one. Where will it make a difference? I think it can make a difference. You know, like Matthew, you meet teams that work on capital allocations policy in NHS England and capital allocations policy in the Department of Health. I can absolutely see the benefits of having one coherent view of what sort of health and care infrastructure do you want for the future, how are you going to fund that, how are you going to get that money out to the system.
Right. And yourself, Matthew?
Yeah, so I think any of us who've worked in organisations that have been through major reorganisations knows that they are weapons of mass distraction. Half your workforce is worrying about keeping all of your workforce is worrying about keeping their job, and that is not the best frame of mind to be in for kind of decision making. I think if you look at the literature around reorganisations, it seems to be that one of the things that makes them more likely to succeed is a really clear account of the direction that you're going in, which refers in a sense to Nick's point. But I think that's why it needs to be connected to a commitment in the centre, and hopefully we'll see this articulated in the 10-year plan to an extent, not to devolve and to empower. So yes, there are areas of duplication and excessive. I think there are thousands of people in the communication and strategy teams, for example. So there are areas where it's pretty clear, if you're willing to not do lots of low-value things, that you can save money. But to take an area that Nick said that has to be done in the centre, or that is done in the centre, and maybe that's a good thing, improvement, what I would say is that NHSE's model of improvement tends to be, we're going to define what needs to be improved, we're going to define how you're going to improve it, and then we're going to censure you if you don't do it in the way that we say we should. Now, I think an approach to improvement should be much more empowering. What the centre should be doing is saying, look, there's all sorts of people interested in improvement. There's NHS Confed, NHS providers, the Royal Colleges, the think tanks. Actually, we need to create a community of people, GERFT, who are interested in improvement. We'll sit in the middle of this. We'll say what we think the national priorities are, but actually what we're trying to do is to empower and enable a culture of improvement rather than do it all ourselves. And I think if you had that kind of approach, that's one of the ways in which this reorganisation would not only save money, but actually make people in the health service a lot happier.
So this is the question. You don't have to answer it, but I'm going to ask each of you. Do you feel this reorganisation will work? Yes or no? Yourself, Matthew?
Yes, but only because I'm an optimist. There are no empirical grounds for it. It's just a reflection of my character.
I don't know.
You don't know.
It's a reflection of your character.
And yourself, Nicholas?
What he said, don't know.
Because the thing I've noticed before I move on to my second point is the morale in the service is rock bottom, and to change structures you need a willingness, and I don't know if the willingness is still there. That may have been pulled out while I wasn't here, but the willingness from, because I do work quite, I do interlink with the organisation. They are concerned. People are worried about their jobs. They don't know what the knock-on effect is, and I'm just worrying. Well, not worrying, but I'm concerned. As will it make a difference that we will struggle for the very thing we want to do, get waiting lists down, get things moving, that will stall it because people don't know what's going on?
I think that if you're working at the front line, most of this feels pretty irrelevant to you, to be frank. What matters to you if you're working in a hospital or mental health trust or primary care, what matters to you is the financial context for the NHS next year, and one assumes this will be confirmed in today's statement, the comprehensive spending review for the next few years is going to be the tightest financial position that the health service has found itself in. Some of the members that I represent are pursuing efficiency targets of 6, 7, 8%. And that's not an efficiency target. That is a requirement to cut back on services, to reconfigure services, to do some quite difficult things. So I think the issue for people out there, and it's been forgotten, I think, a bit in the debate over the last few days, which I completely understand, is that what the real challenge is out in the front line of the health service is how do we do more with less? Because that is a requirement facing almost every part of the health service.
So my final question to all three of you, and just give me 1 point because then we can move on. What do you actually, because I'm trying to be positive here, what do you feel the main opportunities from abolishing NHSE and to improve health outcomes, and how can we realise this? So yourself, Nicholas?
Okay, a clear definition from ministers of what relationship they want with the NHS, and a clear devolution towards the, further down the line to make sure that local people can actually use their own initiative, and then clear lines of accountability, and with that, a clear definition of what integrated care boards are for. Because at the moment they have at least 2 jobs, and there are mixed messages. So at one level it's about the integrating of care, improvement of the neighbourhood and place, working better with local government, the public health agenda, all that sort of stuff. And the other question is, are they in fact responsible for the performance management of their organisations within them? And there has for quite some time been differing views amongst ICB leaders about what that's about, and mixed signals coming from the centre about what they think is the most important. The most recent is that they shouldn't do the performance management. NHS England should do that, but since then we've announced that we're abolishing NHS England. So some clarity on that would help.
Yourself, Siva?
I would say on the positive side, you will reduce some duplication, so the centre will feel a bit more coherent. And also, there is simply no way you can have the same model of command and control and top-down management with so few people. So I think whether you want it or not, you will start trusting, listening, and enabling local leaders to get on with their jobs.
So I'd agree with all of that, but I just also kind of maybe name an elephant that's certainly not in the room, which is it ought to be that this bringing together in the department should be something that assists in the notion of mission-driven government. And after all, health is one of the government's 5 missions. But unfortunately, things have gone very, very quiet when it comes to the health mission. And I think a lot of us were quite excited by that idea, going back to what I said earlier, that only 20% of health outcomes are a reflection of what the NHS does, and we need a much more joined-up whole government approach to a whole variety of issues, from economic inactivity to addressing health inequalities. So it could have been an opportunity to kind of restart that focus on a more holistic approach to health. But as I say, that seems to have gone very, very quiet recently.
You know something, I think that's a really good place to stop. I'm going to hand back to the chair and thank you, and thank you all. Thanks, Chair.
Ben Coleman.
Yes, hello, and I think it's very good to see you all. And Nick, I have to say, I remember the 5 giants starting off and the fantastic work you've done, particularly making the absolutely unclear a little bit clearer. I've always enjoyed it. Can I start with I'd like to pick up and move on, carry on from where we've just got to, but can I just throw something in first, which is a specific point raised with me by a senior consultant, and I just want to know if you've got any insight to this, perhaps one for Matthew. We have at the moment about 80 highly specialised national services which are commissioned and run out of NHS England: DNA repair service, pancreas transplantation, sort of things that affect 500 or fewer people a year. Run out of NHS England. Given that we've discussed, you're not quite clear about where things are going, but would you expect that they would just be moved, transplanted into Department of Health and Social Care, or might it just fall apart?
Well, someone has to do that. More specialist commissioning is being devolved to ICS level, which I agree with, but certain functions, as you say, will need to be approached from a regional or a national level. And I think that speaks to a point we've all made, which is that you can move bits of the organisation together, but there are certain functions that still have to be done, and one of the things you've got to watch out for in a reorganisation is that important things just get forgotten in the general shift. So it's really important, actually, organisations like us have got an important role, I think, in kind of lobbying government around some of these things and saying, in all this change, don't forget that somebody has to do this. I think, Siva's point about cyber, security is a really good example of that. You know, cybersecurity is a massive issue. It's a small team, a vital team. If people took their eye off the ball for that for 6 months, the consequences could be enormous.
Yeah, well, that's good. Thank you, Siva.
I just wanted to come in. I'm really glad you asked the question, because part of this delegation of services towards ICBs was predicated on the capability assessment, where they looked at lots of things, but one of them was commissioning infrastructure. So now we're at a point where specialised commissioning is going to be delegated from a body that's going to be abolished to bodies that are looking at 50% reductions to their running costs. So I think it's a really good question to probe around. Are you still assured that this is a safe transfer of responsibilities?
I'm talking not just about specialised commission, which is about 150 different conditions. I'm talking about highly specialised, which is about 80 of those. If you're treating fewer than 500 people a year for a very complicated disease, how can you devolve that locally?
Yeah, I think, well, back to the theme, nobody knows, but I think whatever model you have, whatever operating model, there will always be some things that are so highly specialised, you do them nationally, and to a certain extent, I think you could be agnostic over whether that's NHS England or the Department of Health. It's that other tier which is actually pretty substantial over where does it go.
Nick, I'm not going to ask you that if you don't mind. I'm going to ask you something else, if that's okay, because you might just, I guess you're going to say what he said, if you don't mind, which is given all of you huge experience and fascinating to listen to. One of the big challenges of maybe doing more with less is that we always talk about the NHS, the 10-year plan, the NHS this, but we've talked about that you can't make what needs to happen now work without, and it was always just a small street state that takes place among my colleaads of how soon and how quickly and how often I'll mention local authorities, so that's today's contribution. But that's worth a tenner to him. How can you talk just about the NHS 10-year plan when you're not talking about the 10-year plan for the NHS and local authorities, which can be from housing to social care, and the voluntary sector? And are we right always in talking about new models for the NHS? And shouldn't we be talking about how we can support different relationships at a local place? Because isn't it the relationships that at the end of the day between the different groupings that deliver the better care?
Well, the short answer is you can't and shouldn't talk about the NHS on its own without looking at social care and local government. And many of you have experience of local government. You've been on health and health and care boards. And it's clear the intention behind the concept of integrated care systems was to get closer working between the NHS and local government. You could actually argue the current Act doesn't really help much by that, because we've got two separate boards trying to do what was originally done by one. But of course you do. And I mean, we keep talking about the elephant in the room. You'd rather than have primary legislation to abolish NHS England, it would be nice to have something substantive on the reform of social care, which would actually which would enable the NHS to perform better. So no, you should not be talking about just the NHS when you're looking at a 10-year plan.
Anyone else want to come in on that?
I think the point about relationships is absolutely right. You know, as I go around the country looking at systems that have made progress and ones that have made less progress, you know, the key variable very often is the quality of local relationships between leaders. Now, you can't make people get on, but what you can do is try to remove incentives which tend to drive people apart. And I think that, as Patricia Hewitt argued in the report that she wrote, 18 months ago, we created integrated care systems, but we never really created the circumstances in which they could flourish. And as Nick said, this issue of performance oversight has been, a difficult issue. In some systems, providers and systems have worked very effectively together. In others, providers have clearly felt a lack of confidence in the system, or they've not really wanted to have system oversight, or they've said, well, we're having oversight from the system, oversight from the region, oversight from the centre, and it's overkill. So I think we've been a bit half-hearted about creating the right incentives which would encourage people to have those kinds of relationships. But actually, that is critical to the sustainability of the health service.
I mean, do you think that doctors, amazing doctors, we've got amazing doctors, amazing nurses, amazing people working in the NHS, but do they really think there is genuinely, in their guts, value to working collaboratively and almost on an authentically equal basis with people in social care, with the voluntary sector, with others? Or is this really always going to be, we'll let you work with us, not really understanding the other parts of the system which need to work with them on a much more equal basis? It's always going to be the autant bas NHS, and everyone else can come in the little gaps that they give them to come in. And if that is the case, will we really ever achieve better healthcare in the country?
It's a brilliant question. It varies enormously from place to place. I speak to provider leaders and I say, how's the system? And they say, well, I am the system. We are the system and we work together. I could point you to a part of the country where certain parts of the provider landscape have agreed to put money into a central pot on the basis that the acute provider agrees to reduce its capacity over time as part of the leftward shift. And that's really, really impressive. And that will drive real change. I could take you to other areas where the providers and the system do not get on effectively at all. And there is a tendency in the kind of acute provider to say, look, the only solution to anything is for us to take over everything. And until we take over everything, nothing's really going to work. So it does vary from place to place.
My quick observation, my quick observation was going to be, I think a lot of that behaviour is being modelled out. I can remember over the course of my career, it was much more either, look, we've just got to do our job. Our job is to run a good hospital and that's it. Not my problem, what happens. And I think a lot of things have changed. Partly the reality of you could be the best run hospital in the world, it is not going to be enough. You are not going to achieve financial balance unless you do things, and we've all seen the same thing. I never thought I'd see the acute finance director say, I'm going to try and free up a portion of my budget to support what would have been covered by the Disabled Facilities Grant, because I know that's what's going to stop people requiring my services. So I think we're getting there, but like Matthew said, it's slowly being modelled out, but it's still spotty and variable. It's not the MO at the moment.
Yeah, exactly. Encouraging. Nick,
no, I'd agree with that. I mean, it is better than it was. It's not perfect.
Good. I'm going to leave it there. Thank you very much.
Thank you so much. Right, so ICBs. We obviously had the announcement about the abolition of NHS England, but in a phone call the same day, and I think, Matthew, you were part of that phone call, were you not? ICBs were being told that they needed to cut their running costs by 50%. I mean, off the back of that announcement, a question to Matthew, where are they? And what more information is there? Is there any more that we've missed somehow?
I think we are going to hear in the next few weeks some more thoughts from the centre about how that 50% cut is achieved. I mean, I'm always uncomfortable about 50% because it's just an arbitrary...
Yeah, it feels like a made-up number.
I think it was 47.3. You'd think someone had actually worked it out, but 50% is a bit like the 50% higher education target many, many years ago. It's a bit plucked from the air. But nevertheless, we are where we are. We in the Confed represent integrated care systems. After a bit of kind of gnashing of teeth and tearing out of hair, we're immediately focused on, okay, what does this mean? And the heart of that question is what is meant by strategic commissioning. So the message is that is where the core focus is. Now, it is important to remember that ICSs do lots of other things, some bits of service delivery and other things, and that's the point we've been making about the centre. Don't forget that there are kind of discrete things that somebody has to do, whatever change you push forward. But in terms of that core role, I think we need to understand. First, we need to understand what strategic commissioning means, and again, I understand there'll be clarification about that to come over the next few weeks. We then have to think about building the capability for strategic commissioning, because I think most people longer in the tooth than me in terms of their health service experience, not in terms of their actual age, I don't want to emphasise, would say that commissioning capacity has declined probably in the health service and has to be rebuilt. And then I think we have to answer some kind of questions about, at the moment in the kind of narrative from the centre, strategic commissioning is good, provider oversight is bad. But how do you do commissioning without oversight? You can't just say to people, look, this is what you've got to do and we'll come back in a year and see if you've done it. You have to kind of make sure that it is being done, and you have to intervene when it's not being done, particularly if what you're commissioning, this is critical, particularly if what you're commissioning is integrated solutions. So you're commissioning things that require people to work effectively together. So that's another thing we need to see the answer to.
And in that, do you see any benefit in the local government reorganisation that's happening in parallel with all of this? Because
I'm going to say no. I simply mean
not really.
Ultimately, one day, yes, but certainly at the moment, you've got both sides of the equation facing unbelievable amounts of churn and difficulty. So it is even harder I think, for us to engage our local government colleagues when they too are facing an set of existential questions.
Very good point.
I think it's worth pointing out that ICBs have already had a 30% cut in staff that they only finished sorting out end of last year, and now they've got another 50%. Now, I don't know this for a fact, maybe Matthew does, but my guess is that much of that cut came on the sort of commissioning side because it was the effect of rolling CCGs into ICBs long ago. And therefore, there's fewer, there's less numbers of people to do commissioning, whether that's not necessarily a comment on the quality of the commissioning, but there are a few people to do it. And if strategic commissioning is going to be, and it comes back to where your 50% cut falls, depends what you want ICBs to do. And we've already talked about that. But if it's strategic commissioning, are you therefore going to cut on the performance oversight bit, even though, as Matthew has just made the point, you kind of need a bit of both. You certainly need some of that for it to work well.
In my local ICB, it was the place-based team that went.
Sorry?
It was the place-based team that went.
Yes.
So
Right.
it was the team that's meant to be delivering neighbourhood health that ended up going as part of the 30% cuts already.
Right.
And my concern is that across other ICBs, that is because there's more people there and there's more places. So if you're looking to make 50% cuts, that's my concern. Well, but I'd be curious to know if you share my concern.
Defeats the integrated that is there in both an ICS and an ICB's title, doesn't it?
Well, just that, yes, I share your concern. Building a new neighbourhood integrated team is not one of the statutory functions of a CCG, so it could be one of the first things to go. Does that mean I need to stop talking?
No, absolutely not. No, we'll carry on.
So I think on the ICBs, that's a really good example of we know what is being destroyed, but we don't yet know what kind of health system is being created, because the last time there were 30% cuts, the narrative was squish ICBs and what they're meant to be doing, make it more focused on strategic commissioning, oversight goes to a region, and then a lot more of the day-to-day commissioning could go to a provider collaborative. Mm-hmm. Now, if all of that is being squeezed at the same time, I think the question becomes, how do you want the health system to work in the future? And probably not for the last time. At the moment, we don't know.
Matthew, do you have any sense, as they're looking at where they can make redundancies, what is the most likely place to go from your ear to the ground?
In integrated care systems?
In integrated care systems,
I think we await further clarity from the centre in relation to that. So I think, in the end, even when you have to make a 50% cut, you want form to follow function. And so until we have a greater clarity about function, and Siva's right, about the relationship between different tiers is obviously going to be important. The operating model is clearly important. Now, it's, I think, going to be a major part of the 10-year plan is going to be around particularly this question of how do you shift resources out of hospital and what is the way in which you organise out-of-hospital care. That itself then boils down to another question, which is ultimately the only way you achieve the kind of shifts that Wes Treating is talking about is if the acute sector consumes a smaller proportion of overall expenditure. As I understand it, we're going at the moment in the opposite direction to that. The question is, who is then going to be responsible for trying to ensure different models of care, different pathways to enable that shift to take place? My own view of that is it doesn't really matter as long as you're really clear about the destination you want to reach. So if you're really clear and the incentives are right and there are national rules that are clear about this, that you're going to reduce the proportion of expenditure that goes through acutes, whether it's acutes that lead on that and then commission primary, community and social care to provide out-of-hospital services, or, as in, for example, East Birmingham, where it's primary, community and social care who, in a sense, commission a diminishing resource from acutes, it doesn't really matter as long as you're clear about the direction you want to take. And then I think the role of ICS is to sit above that, which is largely happening at a place level, as I say, sometimes led by acute, sometimes led more at a kind of neighbourhood level, to sit above that and to ensure that it is actually happening and to take care of those things which fall between organisations, however well integrated you are.
It's very helpful, and we also look forward to getting some clarity about direction. One of the areas we've not talked much about yet is NHS regional teams. Is there anything worth saving there?
Yes.
Yes, says Siva. Okay, go ahead.
I think there's some things like the commissioning of an ambulance service where it makes sense to, but you've got a choice. Again, you've got a choice. You could group together ICBs. And I'll take one step back. Our entire system is predicated on sort of gearing ratios. So you have one national body, you have somewhere between 4 to 10 regions, and that makes sense if you've got somewhere between 50 to 300 local commissioners. If what happens is ICBs start sharing roles and you end up with only about 20 to 25 functional ICBs, there is a question over whether you need a regional presence. But to the extent that you do, things like ambulance commissioning, some specialised commissioning, I think makes sense on that sort of footprint, that sort of geographical footprint.
But if I can make a point about tiers, so a lot of people in the health service will complain about the number of tiers. What I'd say is it's really about how does that tier work. If it's an enabling tier, then it doesn't really matter. So if you're in a system and the providers feel that they are an intrinsic part of the system, they don't describe it as a tier because it's just a place in which they work things out together. Mm-hmm. We published a report from the Confed a while ago about the North East region, where they explicitly had a model which they called the 4+1 model, where the regional chief executive, regional director, was kind of primus inter pares with the 4 ICS chief executives, and they worked together as a team. In that context, the region doesn't feel like a tier overseeing you. It feels like a useful convening space for a whole variety of different things like, specialist commissioning or learning from each other, performance variation, sharing your talent. So I think the critical question for me about regions is, are regions a kind of tier, or are they a convening space for the people, for the systems that work with them? And I think if it's the latter, then they do have a significant and a useful role.
At the moment, they have a pretty large accountability role, particularly regarding their local ICB. So would you suggest that that's one of the things not to save?
They undertake that role in very different ways in different regions, is what I would say. And I think you can have accountability methods which are about learning, and you can have accountability which is about enforcing. And I think the former works better than the latter.
Thank you. Anything to add?
No, I just agree with all of that. Basically, I mean, there are things that the regions do that need to be done somewhere, and ever since the foundation of the NHS, there's been some form of regional tier, possibly for rather a good reason. It's a very large organisation, and now you could, if you ended up with, as you say, maybe 25, 30 ICBs. Then you might not want some of the performance management, accountability, the stuff that sits in the regions at the moment. You might not need a region to do that, but then you would need the ICBs to be doing that themselves. Mm-hmm. Yeah. So you've got to be clear about what you want your ICBs to do, and we are not.
No. So Nick, you are the expert in the last large reorganisation, and it is fair to say, whilst we can't predict the future with what happened in the past, you're a fool not to at least take note. What lessons do you think, as broad principles, it is worth us all bearing in mind as we embark on this brand new path ahead of us?
Well, I hate to sound like a broken record, I would seriously ask the question, why do we need primary legislation to achieve this?
What you keep saying about primary legislation? Tell me why that's the thing.
Well, because can I quote the Secretary of State himself? I could spend a hell of a lot of time in Parliament and a hell of a lot of taxpayers' money changing some job titles, tubing over staff back into the department, changing some email addresses, and not make a single difference to the patient interest. And that has to be the risk when you start legislating. Because it is not just rolling an HSE back into the department. You're going to have to define a whole lot of things that are currently some of them are statutorily defined already, some of them are not. Some of the relationships you can change without the need for legislation. So it seems to me that the crucial question that Wes Streeting needs to answer is, what is it that he cannot do without the legislation? And when that has been explained, is that a sufficient gain to make it worthwhile going through the inevitable disruption that legislation will cause?
And as you say, worthwhile, and I know that IFG and also King's Fund have done work on previous reorganisations, both in the NHS and also in other departments. I mean, what lessons do we have to learn from them? How can this go smoother? You know, how can we make this the best possible reorganisation there ever was? What does that look like?
Well, yeah, I suppose the answer is you need to be very clear about exactly what it is you are trying to achieve and what you're putting in place. You know, Andrew Lansley was entirely clear about what he was wanting to achieve.
That's it. I mean, he had a very clear vision, and look where it ended up.
But it turned out to be unworkable. And, you know, it was completely subverted.
The clarity clearly isn't enough.
Yeah, well, clarity of things that you actually think, that you genuinely believe can be made to work.
Okay.
Right?
Thank you, Siva.
I would agree. I'd say if you're going to do it well, have a very clear story over your rationale for why you're doing it. Have a positive vision not only of what you're destroying, but what you hope to create. Be very aware of the impact created of your decision. So back to the earlier sessions, can you articulate what impact this is going to have on the voluntary sector, who might now be thinking, who do I speak to? How are decisions made of the new system? Treat people well while you're doing it, because there's, you know, I'm not trying to be facetious. There's a good chance you'll be re-employing them at some point in the future. Listen to the people who are telling you this is perhaps not a good idea and have a good argument to that. And the final thing is, be very clear that this is your big thing. Whether you like it or not, if you're merging the biggest quango we have in this country into a Department of State, that is going to be your big thing. So make sure you're resourced to do it well.
So do you, there was a concern raised in my visit to Nottingham ICB yesterday that it's going to be, they don't see how social care can get sorted out at the same time in anywhere near the same scale while this is happening. Yes, we have the Casey review, but they say that they're going to deliver reforms in the next year and we're going to see positive progress on social care. Does it follow from what you're saying that that could be crowded out?
I think on the positive side, there are bits of the Department of Health and Social Care that could be relatively hermetically sealed from this. You know, there was no massive adult social care reform team in NHS England that's going to be disrupted. But you know, there is no permanent perm-sec of the Department of Health and Social Care at the moment, but he or she, what would have been their the number one thing on their to-do list? It would have been either, you know, get out of the operational hole we're in, pull off the biggest set of reforms to healthcare we've had in a generation, or the Casey review. Now I'd guess that the biggest thing on their to-do list is manage this massive machinery of government change well. So yes, I think there will be some distraction and there will be some opportunity cost.
Thank you. Matthew?
Yeah, I mean, I think in the government's defence, they would say that this is a shift they have come to because they feel they have been reasonably clear in their priorities, but that clarity does not seem to have translated itself into action from NHSE, which is a reflection potentially of the fact that NHSE had become such a leviathan that it wasn't really capable of directing its attention in the right kind of way. So this is a response, I think, to what the Secretary of State and others experienced in terms of the capacity of NHSE to focus in the way that they wanted to. So I would entirely endorse Siva's points and Nick's points about the purpose of this. In the end, what you've got to return to, and the question for the Secretary of State, is you are seeking to recover services and to reform services in the tightest financial context that the NHS has faced. How do you do? What is your fundamental model of change in relation to that? A final point about social care is that I do think, and the Secretary of State, of course, earlier this week talked about social care being part of potentially the kind of 10-year plan and wanting to do something there. I do think that if you do integrate social care more effectively at a place level, and you see the connections between effective social care and reducing demand on the health service, on the front door of the health service, getting people out of hospital more quickly, you can potentially create a benign feedback loop whereby you start to see that social care investment more than pays for itself in terms of the impact it has on health demand. But you have to design that incredibly effectively at a local level.
I think, especially given we've got the spring statement in front of us, that we should probably end there. So I will say thank you to you all. We could have had hours more with you, all three panels. But thank you for coming at such short notice.